was involved. Local community is at the fingertips of every church in this continent. You have a huge resource that nobody else has. You have a community that can listen when it hurts, that can provide primary mental health care. Here are the pictures from Kalehe in DRC last year, when we trained community counselors to listen to those who suffered from that enormous landslide and lost families and communities. And friends, we need new ways to build not only a motivated, but a well-paid workforce, so that workers stop looking at the very carrots hanging out there, oh, well, let me go there, but they stay and stick where their families are. And I hope we can discuss that today. What are the solutions to do that? And then we need to move on finding sustainable financing. If we have communities at the heart of the solution, we have health workers, and you have so many young people. We just need to train them and retain them in the system. We also have communities who can contribute to funding. Yes, have a strong advocacy to advocate with your governments, but building on our Christian value of solidarity, or let me say it, caring for one another, we need to challenge our theologians and develop a theology of teaching them risk sharing. Teach in our churches what it means to share together the cost of healthcare. You have millions of people, and if every person in a church gives $1, you have millions of dollars to do and sustain your church health services. In French, we talk about the mutuelle, and it's already there in the word. Caring for one another, community-based financing. And today we have digital methodology. We can really collect $1 without any cost using mobile money. Friends, we now need to think in afresh, not to look at all the Gates and the UN money, but look at the local resources that your church, your community can provide in building a foundation of sustainable health financing. And of course, there will be another innovative ways. We are testing just one in DRC, where people for their families save money on their mobile phones that they can use for healthcare. The churches and mobilize the communities to actually provide sustainable health financing. It's the bedrock. We will fail bridging the last gap if we will not provide the money that is needed to keep those health workers where they are needed, to give them a good environment, to be able to buy those medicines, and to get local production going to sustain health care. I don't need to talk about the medicines. You will do that here today. But I want to put an emphasis on what the role of Christian health associations is. I really think that every country needs one strong voice from the FBO sector. We have EPN, we have ACHAP, we have other instruments that can really be the voice of those people that have no voice in the community. We have digital means today to collect those data we always struggled with for many years. We have struggled with documentation in Christian hospitals and health facilities. It was difficult. We were not represented. But we can today, because by digital means and using digital solutions, we can provide those data and play the role in the national health system that we need to play. And then we should be using implementation research. Yes, we are not academia, we are not foundation research, but let's look at the experience we are making. Publish them, collect your data, get a face, in publications, say, look, this is what we do in Liberia, this is our experience in Sierra Leone, this is what we experience in Guinea or in DRC. We can do much better. EPN has given us an example. They have published quite a few papers. I think we can do much better by using the data and using the work that we are actually doing. I want to conclude by emphasizing churches still have an important contribution to make to reaching access to care, especially for those at the margins. The churches are there where the people live that have no voice. They are out there in the rural areas, in those villages. They can look out for those forgotten people in our cities that are marginalized, for women, for those suffering from gender-based violence and many others. We have a task of caring, of holistic care. And we have an intrinsic motivation to do that, even in crisis situations. When Ebola broke out, it was the Christian Health Association that was out in Foya Boma in the north of Liberia, strengthening those Christian hospitals that were suffering because they had lost their friends. And Christian health services should not work in a silo, but they must be integrated in national health systems. And we can use the Christian health associations much stronger than we did in the past to really integrate our FBO services and system into the national health services. And then, of course, yes, we need to raise our voices. We need to be heard, and this ministry we do should be seen. So start publishing, start reporting on your results, on your successes. We heard yesterday wonderful stories, wonderful successes, but they need to get out there and they need to be heard by the community. When the money is divided, when the policies are made, I think you should be there. And yes, we are going to have new crisis situation, and the climate change and the climate crisis is upon us. The happening of Kalehi that I just mentioned in DRC is just one tip of the iceberg. We'll face many, many more. So I think it really is important to work together. We have something that nobody else has. We have a common root across countries, across our very, very cultural differences. We have a common root, we have common values. We can work together to make health for all finally a reality. And I would like you to really thank with us all today those working tirelessly in difficult situations. They are not here today. They are out there at the moment, providing care in the cholera epidemic, providing care for those women who are violated, are there where it really hurts. And I want to thank each and every one in the committed Christian health services that is out there to give those services. And thank you for EPN to pulling us all together. And I would like to encourage ACHAP to do the same, work together for a greater good, and may God bless us all. And let's not stand here in 40 years and say we still haven't done it.
Thank you, Dr. Gisela. So many reflections. We'll have our next speaker is Daniel Karimi. I believe you're online, Daniel, and you will speak about towards sustainable medicines access. Over to you.
Okay, ladies and gentlemen, we are trying to get our next speaker who is online. We are trying to get that. Thank you very much. Shortly, I think we will be okay. Dr. Dennis? Yes, please. Let us please go ahead and get to the next speaker. We are trying to get the one online. Yeah, we will take him after this one.
No problem. We always have a lot of things to discuss. Obviously after these two presentations, we will have a panel discussion as well, and we have a number of questions, and then we will obviously open it up to the audience as well. For the panel discussions, we do have two colleagues, Dr. Steve Kisambo, who I believe was not able to make it. He is from CBCA DRC, and he was supposed to speak to share his perspectives on Ebola to COVID-19 versus childhood communicable diseases, building better preparedness for the church health system beyond sharing recipes. And our other speaker is Gertrude Guveha, and she is a trained nurse and is also leading, I believe, training for ZAC, right? And Gertrude will speak about reimagining communities and community health promoters' role in accelerating access to healthcare. She has over 41 years in delivering within the health system, 11 years in INGOs, particularly in the areas of pediatric and adult HIV care support and treatment, especially in the hard-to-reach areas. Currently serves as the head of training department for Zimbabwe Association of Church-Related Hospitals. Gertrude, over to you to speak about reimagining communities and community health promoters' role in accelerating access to healthcare for all. Dr. Giselle, do you also want to come up, please?
Hello and good morning, everyone. Is it still morning?
I'll
Yes.
come back to you. I'll come back to you. Oh, are you going to speak? So hopefully Daniel is able to join. We will adapt ourselves. We will switch while we go. But let me just start to the panel conversations, okay? And so, Gertrude, please be patient. I'm going to start with a couple of questions for Dr. Giselle, and then I'll come to your section, which is on community health promoters, and that's what you wanted to talk. Obviously, Dr. Giselle, Can you speak from your experience? You shared a lot of great things, especially what struck me was your healing ministry, caring for others, people-centered, and local sustainable funding mechanisms, all excellent stuff, and also raising our voices, especially our ability to tell our impact stories. I represent an organization, IMA World Health, and IMA World Health is an organization that started in 1960s, and our parent company is called Chorus International, which includes Lutheran World Relief, that started in 1945. But one of the things that we did was working with ACHAP to help them tell their impact stories. In other words, organizing training sessions on technical writing. So what you said clearly reflects, and I think it is a capacity strengthening that could be replicated elsewhere as well. Can you, Dr. Chisela, speak about what lessons have we learned from the past health crisis that can inform better preparedness planning for our church health systems?
Well, thank you very much.
Is this better?
Yeah.
Yeah, it's unfortunate that our online speaker is not just able, because this is exactly what he was supposed to be speaking on, in how do we tackle the crisis situation and what role can the churches play in that. And I would just like to elaborate a little bit on our experience we had during the Ebola crisis. During the Ebola crisis, the situation in West Africa, both of the Christian health associations that were there in Sierra Leone and Liberia weren't really prepared in how to respond to an epidemic. And they were suddenly there faced with the fact that health workers died in their facilities, there were no supplies. There was huge lacks, and I think we have learned a lot since then in building up pandemic and epidemic preparedness, strengthening, for example, the IPC systems in our health facilities, ensuring that our health facilities are safe places and they're not dangerous places. People were afraid working there because they said, well, if I go to work, I will get infected and then I die, how my colleagues died. So I think it's a big responsibility, and EPN plays a role, and pharmaceutical and of course medical supplies play an important role, that they are sustainably there so that your health facilities can be protected in a stage of crisis. And we shouldn't be waiting for crises to come, because there will be more crises arising as we go along. We see it now as Mpox in DRC. It doesn't stop. We had Ebola, then we have cholera, then there is Mpox, there are other crises, and again, it's the same thing that we need to do. It starts at the community level, and WHO has even a word for it. They call it RCCE. Risk communication and community empowerment. And I know Dr. Tedros is really very strong on really involving communities and strengthening their primary healthcare approach. Who is better placed to do that risk communication? Who is better placed than those Christian facilities? They are out in the community, they speak their language, they have the trust of the people. DFM we were doing a study as we were supporting churches to respond during the COVID crisis in DRC. And we were looking at what role did the church play. And we realized once church leaders were trained, once church leaders were communicated and they understood what it really meant, they were able to communicate that to their communities. And we have shown in that study that the acceptance rate of COVID vaccine in the areas where church leaders were positively influencing the community had a much higher acceptance than those where they didn't play that role. So take the pandemic preparedness. It is important that the church plays its role and that we work together with government, that we have one monitoring committee per country that really monitors, but the data of the church facilities need to be transmitted to that central database so that we know about cases, about follow-up, about surveillance, and everything else that is needed. So if we play that integrated part into the national health system and we use our strength at community level, we can really make a difference in that field of pandemic preparedness. And
Very good. Very good. Thanks, Dr. Gisela. Can you also speak a little bit about, I mean, obviously you worked as a missionary physician. That closely resonates with my background too. How do you envision the role of church health system in the next 5 to 10 years, for example?
That's a small question he's asking, huh? Well, I think the big crisis that is upon us and that we are already realizing is the effects climate change has. And again, I think there's a lot local community can do. Local community can do in order to recognize what are the effects in our community, how can we mitigate the effects. Where people are pushed away, I mean, we have already areas in the world where people have to move. They become internally displaced because of flooding or because of drought and other issues. We suddenly see new diseases coming up. And it's being alert, being vigilant on the local level to report observations and to say this is happening in our community and we would like to respond. And I think churches can mobilize communities to respond to the crisis and to say what can we do, how do we use our resources and what role can we play. And I think in this whole discussion the local community needs to be involved. It shouldn't come from the outside that you say you should do this and you should do that. But let's listen to the local community who knows the local situation to get responses that are appropriate for the local action.
Very good, excellent. One of the projects that in my organization we are leading is a project called Momentum Integrated Health Resilience, which is a $200 million USAID's flagship project that's aimed at building resilient health systems. You alluded to community health financing. What from your experience are some of the ways what does a church building resilient health system look like for church health systems? Do you have some other reflections aside from community health financing? Any other thoughts or examples you're able to share?
Well, I think health financing is something that the churches that we as Christian health associations should be really tackling in the next few years, because without finances, everything else will fall. So waiting for international funding is one way, and mobilizing international funding, but actually looking at what are local resources that we can use. And I think there is no answer that one fits all, but it means that a local setting in any country, you have to look at what is the situation there. I know the example of Uganda, Streamline. I don't know whether anybody is here that knows Streamline, which they started in a small hospital in Kisisi in Uganda. And they started with a very, very small community where the trust was built to do community financing. And now they're in a position over the Uganda Protestant Medical Bureau. They're rolling out a system over the country. And I think trust is the biggest and most important currency when it comes to community financing. If there's no trust, then no scheme will work. So we need to build on a trust, and we need to ensure that the systems are in a way that they cannot be hampered with, that the money is safe, and whatever is saved, it will be used for healthcare and not for any other purposes. So I think there's a lot that can be done along those lines, and everybody in every country should be mobilized to think in their local setting, how can they mobilize those resources?
Very good, excellent. Trust, that'll reflect a lot in our conversation today as well. I believe our speaker, Daniel Karimi, is online, and I'll hand over to you to speak about your topic.
Hello? 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 Can you hear me? It's like there's still an issue.
Can hear you.
Dr. Dennis, confirm if you can hear me.
Yeah, yes, I can hear you. We hear you. You can speak a little louder if that's okay.
Thank you. I see on the chat that I can be heard. So good morning, colleagues. Sorry for all this. I hope now we can continue. So allow me to show my slides. Yeah, as introduced, I'm Daniel Karimi, working as a Senior Technical Advisor in the Promoting the Quality of Medicines Plus program, PQF Plus program of USAID, a program with the broad objective of strengthening medical product quality assurance systems. It's a global program, and we have several interrelated and complementary objectives, cutting across increasing supply of medicines, strengthening QA governance systems, and several others. So I'll be taking you through in the next few minutes. I'll be speaking about the topic of the imperative of accelerating healthcare for all. And I'll take a small area of that. My presentation is titled, as you can see, Towards Sustainable Medicines Access. And we are in the process of reviewing East Africa Community policies and laws. And at the end, as we put things in the context of VPN, I'll request for you to supplement some of these areas, either now or later in our subsequent discussions. And the premise I'm building on that, especially linking with the topic, is linking healthcare with local manufacturing, and then looking at practices, laws, and policies as a subset of in the area as contributing to pharmaceutical manufacturing and procurement. So the outline of my presentation will be to look at the background, look at the EAC, regional vision for local manufacturing and procurement. I'll review some highlights. I'll present some review highlights so far, what we have gathered, and additionally on some ongoing interventions that I'll just mention.
Daniel,
and then ask ourselves, how can EPN contribute and also benefit from what's going on in the context of policies, practices, and laws.
Daniel, if you are sharing slides.
So as a way of background, laying the foundation of this conversation, we all know the benefits of local pharmaceutical manufacturing, and a lot has been said about it, and especially now in the last few years, post-COVID, during COVID, that Africa and many other low and middle income countries were almost left to their devices and almost only relying on what could be done internally. So local manufacturing took a center stage, and we are going to look at what then it's contributing towards healthcare security. So broadly, the benefits are mitigating public health risks, essentially presenting the solutions to the health risks that emerge, and also optimizing the opportunities of liberalized trade and integration. Remember, this is technically a private sector affair in terms of investors in local manufacturing, those that set up manufacturing facilities, those that trade in medicines. So they also need a level of sustainability so that then they are able to present or to meet the needs of the public health requirements. And therefore, promoting local manufacturing is critical. to accelerating access and also economic development. And therefore, underdeveloped local manufacturing contributes to health and economic disparities. Knowing the benefits of local manufacturing, knowing the benefits of what local procurement then could present in terms of public health and economic needs, then raises the question of disparity. And promotion of that then starts to alleviate the disparities. And I think, as Dr. Dennis said in the introduction, that health is a human rights issue. So the moment you alleviate disparities, you are now beginning to meet the human rights from that perspective. And the ideal situation of product security is balancing public health needs and manufacturer sustainability. And remember, this is just about products, because we know the healthcare space has so many other factors, from HR to the knowledge base and so many other things. So this conversation, we are just limiting to product security. Product security is a contribution to health care access. And creating a supportive policy environment for manufacturers and broadly health providers is therefore a key enabler in securing health access. We know that more often than not, provision of healthcare to citizens is a duty of the governments. It's a public health issue, public security issue, and we also know that EPN health system, and specifically the supply chain, is a recognized partner in health services provision, especially in the region of East Africa and beyond. So this background then seeks, after looking at that background, then we ask ourselves what objective that we are going to have is we are going to review the current legislative, institutional policy framework governing the procurement of pharmaceuticals in each of the EAC countries. That's the activity that is ongoing. And we'll also be seeking to identify areas that require improvement in the area of policies and legal provisions. The regional vision of local manufacturing and procurement has been studied, and there's a lot of literature towards this. But one of the overarching strategy is the East Africa Region Pharmaceutical Manufacturing Plan of Action. 10 years plan that has several targets, and just 3 of them is reducing the dependency of imports from outside Africa from 70 to 50, and by the end of the 10 years to 20 to 50% of purchases should be from EAC manufacturers. And also the strategy seeks to expand the product portfolio of EAC farms to cater for over 90% of disease conditions that are common in the East African community. So this is just one of the strategies, but it's the broadest when we look at literature in the review that's going on, because there are various others that involve even the trade area, market protocols, and various agreements between medicines regulatory authorities. So this since 2017, that's 7 years on. So the question one wants to ask is, what is the progress, in meeting these goals and others that have been set? And are there supporting policies, laws, and good practices in the related challenges? If they are not, these instruments are not in place, and what still needs to be done to accelerate achievements of the target in the next at least 3 years towards completion of the strategy period. And at the end, we'll ask, how is it in the faith-based context where this audience is, and how is EPN contributing or benefiting from the situation that we are having? So the next 2 slides, we look at a brief of the highlights, a brief highlight of our findings so far, and is in 2 sections, where we are looking at those instruments that are enablers of manufacturing, local manufacturing and local procurement. And the review, broadening it up beyond policies and laws, we looked at, we found that there are various protocols that are in place, especially at the EAC level, various frameworks. We look at the practices that are in place and many other initiatives at the EAC level and also at the national level across the 8 countries of the EAC community. So what we are finding, and is part of the enablers of to us answering the question, is that we found a level of homogeneity in the national public procurement and disposal regulations. We know that this is what governs the process of funds are allowed to procure, and it looks at processes, the limits, the various incentives, and various channels in case there are disputes and conclusions, contracting, and all that. And we found a level of homogeneity across that, which one would think is a good thing. Even at the EAC level, there are certain guidelines that are given, and that seemed to correlate with what we found at the national level. So out of the 8 countries, at least 5 of them have these public procurement disposal acts and regulations. And some common threads that we are seeing is that most of them, again, specify the margins of preference. Margins of preference in terms of price, essentially saying if you are a manufacturer and you are submitting an interest in supplying medicines in a certain country, you have a certain percentage preference in terms of price. And that's a good thing. Although on the next slide, we'll see how then it also contradicts when we're looking at the regional context. We're also seeing a number of cases where the regulations and the acts indicate guidance on restricted tenders, basically saying a country, for example, Rwanda, that this tender is restricted for only Rwanda manufacturers. This tender is restricted for only the specific country, and that provides opportunities for growth of local manufacturing and also securing options in terms of delivery institutions. Also, a level of reciprocity, at least we've seen that in one country, saying that country X, if you are buying from country Y, if you give us a certain preference, we are also going to reciprocate and give you the same. Thinking about it, that's good, but then again, it's not at EAC level, it's at the country by country level. So one country which has offered to the other countries will be finding out whether that has led to improvement of opportunities of local procurements. Also, in a number of other countries, we've seen innovative manufacturer support mechanisms like economic zones, tax incentives, saying that you pay lower taxes as a manufacturer in the initial years of operation, depending on the kind of public request for supplies, and then you're able to enjoy the incentives. Also, regulatory harmonization, very important, because if we look at EAC as one region, one community, then harmonizing those and doing it jointly, then issues of access of market then become easier. So then medicines regulatory authorities are carrying out joint inspections, joint registrations, and surveillance of medicines, essentially assuring access to quality medicines across the region. Also, issues of pool procurement, I know is a live process at EAC level, but you are also seeing in one country that has a certain mechanism where a public institution is allowed to procure and then procure internationally or locally and then supply to public and private institutions. And that's how it's unique, because this then brings the integration or point of integration between public and private health systems. And one can imagine that EPN, this is an area that EPN would do. Still on the review, we found we are finding some impediments that impede essentially local manufacturing, both at manufacturing and procurement levels. And looking at the language of some of these documents, there's an unclear view of what local manufacturing is. Is it at national or at a regional level? In other instances, some clauses read that local manufacturing is entails only manufacturers that are domiciled in the country. At EAC level, it wants to look at local. In the next slide, I'm going to mention how that is also being addressed. It's an impediment at the moment because if certain incentives are tied to local manufacturers as defined as only national, it means then that manufacturers in other regions are not able, and they're actually treated as outsiders, essentially not benefit the certain incentives. Then, out of the 8 countries, we know that there are 3 countries that are leading, at least have a more mature manufacturing sector, and then the rest, 4 to 5 countries, have nascent manufacturing center, essentially meaning that there's low capacity and lean manufacturing support. And that's where some of these mechanisms, if they are national, may not work, because if a country has one manufacturer and then you limit and you say you'll be buying 50% or 30%, 60%, then there's a contradiction there because they'll not be able to meet that.
Recording in progress.
Different quality standards, meaning that usually if the procurements are publicly funded, they can be limited to purchasing within the country. But if in cases where donors are involved, we begin seeing different, higher quality standards, meaning that not many of the local manufacturers are able to meet that standard. Of course, there are efforts to try and uplift that, and especially tying that with the maturity levels of the countries, then this effort at least to try and improve quality standards of the products through improvement of compliance levels of manufacturers. Then the issue of data visibility, because as manufacturers, they want to see what's the demand like, what's the market size like, how is the consumption in the past, how are the projections into the future. So insufficient data visibility is also affecting what manufacturers are able to do, so that then they are able to bid for business, invest in development of products, and continuous improvement. And then there's no regional policy on pool procurement. I think I've mentioned that, but we all know that EAC is working towards that. And in some cases where there are different forms of government, like centralized versus decentralized, it begins now breaking the market from a national, in cases where certain countries have a governance, have 2 governance levels. So purchasing is happening at the national level, and in other cases it's happening at the decentralized regions. A good case in point is Kenya, and that now begins to break down the markets. Then also the low health budgets. We know about the Abuja Declaration of the 15%. Not many countries are able to meet that, essentially meaning that even their procurement budgets are limited. And what that does is it makes the procurement overly price sensitive, because you want to stretch the dollar, you want to buy as much as possible, meaning you want to buy as cheap as possible. Again, it becomes difficult for local manufacturers to compete in certain situations, and therefore that becomes an impediment. So having studied in the middle, right in the middle of, we are at a point where we are asking ourselves, then what's the extent of implementation of these plans that are there at the regional level and also at the EAC level, and what's the effectiveness? And that's where we'll be engaging you at some point. But you also want to look at the ongoing interventions. We know that at the East African Legislative Assembly, EALA, we know that the institution is developing a law pertaining to regional manufacturing. Looking at the bill, which is in draft form, and SPQM Plus, we've been involved, is trying to redefine local manufacturing. and infusing regional manufacturing and looking at EAC as one local market. So by the time it's completed, we look at the final provisions and hope that it's defined as such to ease then access of the products and commodities for the public. It will be it will be more accessible. It's also expanding options, basically looking at the region and also then increasing access. That's an ongoing work. A second initiative is EAC is processing 8 proposed molecules for restricted importation into the EAC. Again, this is just a starting point, knowing that the range of products required is much bigger, but there's a pilot stage where we're trying to see, having determined that these 8 products, local manufacturers have capacity to produce this, how can they then be restricted to EAC manufacturers on? Of course, procure more from them, increase the security of the products, increase the access. And working with the EAC Secretariat, the PQM Plus program, through this process, will be developing a policy brief. And this lays the foundation of the work that we are doing. So now bringing it closer home, we ask how can EPN contribute or benefit from the initiatives, especially one would look at benefiting from the enablers that are there, and how can we contribute into reducing the impediments and essentially also supporting the broader goal of the East African plan of buying 50%, of increasing the contribution of local manufacturing. And as if to start that conversation, the would ask is, as EPN, do you have any internal guidelines for preferential procurement of locally manufactured products? Those that are looking at local as national or even regionally in the countries that EPN has a presence that are manufactured in those regions. Are there any internal guidelines for preferential sourcing? Number 2, to what extent does EPN source from local manufacturers? And how would you rate, looking at the DSOs, possibly, how would you rate the responsiveness of East African manufacturers to request for procurement, bidding, quotation, essentially asking, is it possible then that it's the manufacturers that are also not very responsive, would want to find that out? And how reliable do you find East African manufacturers in meeting supply requirements? Once you make effort and probably contract them, how does it go? We know there's a manufacturer and supplier, reference checks that are done and record of performance, all that. How has it been? And what legal or policy suggestions do you have, would you give to improve your ability to source from local manufacturing? Essentially trying to answer and helping the East African community in answering the questions of a strategy. So basically, the broader question would tapping into the positive practices and also developing internal processes. As I finish, I think with the EPN, SPQM Plus a program, EPN is one of our field partners, so we collaborate in a number of initiatives. Thank you very much.
Very good. Thank you so much, Daniel. Despite technology glitches and starting trouble, glad you were able to make it. I'll come back to you with a question later. But let me just switch to Gertrude and the topic that she will be speaking. Community health promoters obviously are key to achieving universal health coverage.
Oh, and I can't hear you, Dr. Dennis.
Yeah, no, I'll come back to you later. Hold on. Okay? Community health workers fill an important gap in reducing inequities, especially as they reach the last mile. Obviously, we all work in this context. And the context that we work in are often limited in terms of health workforce, and health workforce are inequitably distributed. We know that community health promoters are the backbone that bridge households and healthcare facilities. And obviously they are trusted, culturally appropriate, and well suited to deliver a host of healthcare services that includes promotion, prevention, treatment. We ask these fundamental questions. How effective are community health workers in reaching the most disadvantaged populations in fragile context? What evidence does exist in their ability to reduce health inequities in the populations, among the populations we serve? And what services, whether it's promotion, prevention, treatment, they offer has the greatest impact? Gertrude is obviously well placed to share some of her experiences. If I may ask you, Gertrude, in what ways can community health workers be empowered to effectively bridge gaps in healthcare access? And maybe you can share Zimbabwe as well.
Thank you very much. Once again, good afternoon, everyone. My name is Gertrude Gouveia, and I work for Zimbabwe Association of Church-Related Hospitals, which is a mother body for the mission and council hospitals in Zimbabwe, as such as a membership of 61 clinics and 73 hospitals, of which some of the hospitals are designated district hospitals, and 16 of these are found in the urban areas, which means most of them are deep-rooted in the rural areas. And of course, you know, as churches, we go where the people are and we take the service where the people are. So most of our healthcare facilities are in the marginalized areas where people are of poor income and little resourced. So this is where we are as such. And I think I'm going to talk about my experience from the field. And specifically when COVID took a toll, and this was a pandemic and Zimbabwe was not spared. So we got funding from ACHAP to increase vaccine surge in our country. So we went to the ministry, we had a meeting with the ministry, and we got to one of the provinces where there was low uptake of the vaccine. And we didn't know why. And so when we, our modus operandi was like, we started with a baseline survey, and we worked with the community health workers. And we sort of made a mapping exercise to find out who's doing what in the province. And we did a baseline survey involving these community health workers, including the churches. Remember, they are also members of the church, some of these community health workers, even the church leaders. And what we found out was amazing. These people were saying, this vaccine is just being pushed on us. We really don't know. You remember there were myths and misconceptions about the vaccine. And ours was coming from China. And they were saying maybe the Chinese want to wipe us out. And maybe, you know, some people just try to politicize things where there is no politics. But we discovered that it wasn't their fault. They lacked the knowledge. Nobody really took them on board on planning and implementation of the vaccine program. And it's like when the vaccine came, we all know that it's like we put the cart before the horse. People were dying, so we're trying to save people. And of course, the vaccine came as a game changer. But to the person who is at the back of beyond, who didn't have any knowledge, no television, no pamphlet, no nothing, they would resist, of course. So this is where we came in as such. We started with community dialogues. and we also involved the churches. And the church leaders then told us that you start programs, you don't involve us, the church leaders, but you forget that we are powerful in the community. Once I stand in front as the priest or the pastor, I preach about vaccine, everybody will run. But they didn't have the knowledge. So this is one of the lessons that we learned. And we took the community leaders and the church leaders on board, and we started capacitating them after the baseline findings. And it really helped the vaccine uptake. And numbers were going up. And remember, we also have vaccine hesitancy groups in my country. So some of the people from the community would talk to some of these church groups who were vaccine hesitant. And surprisingly, some of these were going through to the clinics nicodemously at night. They were getting vaccinated themselves and their children. Or maybe they would pretend they are going to the forest just to pick firewood for their use at home. And the nurse would carry a vaccine carrier in her big bag, pretending as if she's going on a journey somewhere. And she would meet these women in the forest, vaccinate them. They would leave the cards at the clinic. And this is how we started. And it really worked when we started engaging the community and capacitating them. Then, of course, we have also another group of community health workers called village health workers, which is an important arm in our health sector. As a country right now, we have brain drain. Doctors are leaving, nurses are leaving, pharmacists are leaving, you name it, the nurses, even to the general and to the cleaner, everyone is leaving for greener pastures. So we have programs like malaria, where we have trained the village health workers to test and to treat uncomplicated cases. Somebody comes with, train them on the symptoms, and they know. We have trained them on testing, and they test for malaria, but of course they only treat the uncomplicated cases, and they review the patient within 24 hours. If there's no change, they refer to the hospital. And by this, we're encouraging them to minimize the 3 delays. And also, we have empowered them to do family planning services. Remember, some of these clients for family planning, they stay very far from the rural health center or from the hospital. So these community health workers who operate within their villages, and it's like usually they cover a 10-kilometer radius within their village. So they supply all the family planning services, unless otherwise that woman has a problem. And by that, it has helped also to increase the uptake of family planning services. And also it has reduced defaulters, because the service is being done at the doorstep. And of course, malnutrition is one of our problems that we have, and especially when we're faced with drought. They are also trained in giving vitamin A, micronutrient supplements. And this has worked very well. And we also train them in integration to work with others. They will look around and see who is doing what in their area. Be it education, be it health. You know, there are some health programs that also involve education sector, or the WASH, and they work together with other stakeholders. And this has made a lot of saving on resources, and also have bridged the gap, be it of knowledge or of services, because we are using these community health workers as health providers. that stay within a local community. I've talked about defaulter tracking and also treatment of minor ailments. But of course, we have motorized them. When I say motorized, I don't mean motor cars. We have provided bicycles for them. 4x4 bicycles with maybe bigger wheels that can be used in the terrain so that at least they can be mobile enough to take the service to the people. Remember, I talked about working within a 10-kilometer radius, and that has worked very well, and we have seen a lot of positive change towards health within communities. And also they do index texting. We have trained them on index texting, or they refer the client rather to the health facility. And also it has also increased the number of uptake of art. And also we have introduced a bit of e-health where they were provided with Android phones. And this is in the malaria program, where they report cases on a daily basis to the clinic via the SMS or the WhatsApp platform. And with that, it's like maybe at times per district there could be one vehicle, one ambulance. And they are able to communicate to the health center and report cases. If they have serious cases, then modalities will be made to go and ferry those clients to the hospital. So these are some of the strategies that we have used so that at least we increase uptake of service, and also we improve care to the community that is marginalized. And these are some of the rethinking and the modeling, and also the, what can I say? You know, when you are trying to add on workload on, when you are trying to change capacity of people in certain areas. Yes, of course, at times there's not much that you can do, but the little that you do, and together we are making a lot of difference. We have averted many deaths, we have averted many serious illnesses, we have averted defaulters, and we have also made a saving on the not so much bill for the hospital, and also maybe for us where our GDP is very little, we haven't put much strain on the health delivery system. And also considering that at a rural health center, a clinic, there could be 2 nurses only. At a given time, it's either the nurse is on leave, the nurse is on night duty, and half the time you find there's one nurse who's supposed to be running the OI clinic, who's supposed to be running the MCH clinic, who's supposed to be taking care of the sick, who's supposed to be doing the family planning clinic, and maybe who's supposed to be attending the local meetings with the health center committees. And then it becomes very cumbersome for this oneness. But you know, when you capacitate and you involve these community health workers, workload is almost halved to this rural health center nurse. I think I rest my case.
Thank you so much, Gertrude. A lot of questions come to mind, one of which was, what is the impact? You spoke about the COVID vaccine. That's a project we were working with ACHAP, and so it was implemented in Zimbabwe and Sierra Leone and a few other places. But I can tell the impact because I know. In a little over 1 year, that project vaccinated over 1.2 million people. And so that's the power of that, what you said. I know that because I was overseeing that project. But thank you so much. You know, I have a couple more questions, but in the interest of time, want to open it up to the audience for any questions you may have for all of our three panelists.
And Dr. Dennis?
Yes? Oh, yeah.
Yes, let me start. As we get to the questions, I think we need a little bit of an energizer. Let me come up and help you with that. Okay?
I know you are having a good time. Come.
Yes, ladies and gentlemen, yes, as we prepare for our questions, a small energizer, let us stand up. Okay, just stand up and stand up. I don't even think the trick is working because the people who were, the energizer was intended for, they are still sitting. Okay, I think now the trick is working. If you have a raw stand up, okay. All right, we'll do the doms. The doms. We'll start with our wisdom. Give me my wisdom. Give me my wisdom, you say, give me my wisdom. 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 Give me my kingdom. Give me my kingdom. Give me my kingdom. And we are still going down. You can imagine which is the next dom. Give me my condom. Give me my condom. Give me my condom. Give me my condom. Okay, thank you very much, Dr. Dennis.
Very good job. Your laughing itself is a good energizer.
While you're preparing your questions, I just would like to say what Sister Gertrude just mentioned and told the story of her situation in Zimbabwe was just underlining what I was trying to explain, the power of community that we narrate and underestimate. And if we mobilize that, then a difference can be made.
Stand up. You can sit down. The microphone will not reach. Good afternoon. No, sit. Good afternoon, everybody. I'm Nya Fidelis from Presbyterian Health Services in Cameroon. I have two questions, one for sister from Zimbabwe and one from the speaker online. Yeah, let me start with the sister from Zimbabwe. Yeah, the aspect of community health workers, we've also seen benefits of it in our health services, but we have one challenge. We saw community health workers. We had a leprosy outbreak in a health district recently, and we wrote a project was funded by Bread for the World, and in that project, the community health workers were quite integrated to help us fish these patients that were in the hinterlands and bring them to the health facilities, or identify them and tell the facility to go for them and handle them. They were so instrumental. And then the community workers then were motivated under this project, and they were very active in helping us to get these patients or reach out to point out where these patients are in, because leprosy came and the community don't know what was leprosy again. It was eradicated disease that resurfaced. So now they were helping us. We trained them to be able to see it, and because the confusion was that it was fungi, skin fungi. They were able to see and then tell us that there's somebody that is suspected, then we go there and then fish them out. But now when the project ended, the motivation for the community workers also ended with that funding. But we have seen the need and the importance of these community workers, and we need them in our services. Now, in the case of Zimbabwe, how are they motivated to keep on doing the community work that the hospital wants?
Thank you for the question. In Zimbabwe, the community health workers don't work specifically, for a specific program. These programs come and go, and for sustainability, we have maybe a little stipend that they have, and we sit down as stakeholders in a specific area. And at the moment, our Ministry of Health provides allowances. They're just allowances. They're not even a salary or what. I can't even mention them. But you know, at times they get some bicycles like this in the project. They get bicycles in other projects, and these bicycles remain theirs even if the project ends. So there's sort of some win-win situation, but there's a stipend from the Ministry of Health. But also when they come for training, we give them allowances. We also give them allowances for the airtime to communicate. And also, whenever we get some freebies, we also distribute to them. But basically, some of them really are so committed that at times they don't even complain because they are working within their community. They are working within their village.
Okay.
But yes, it's a problem, especially maybe there are these maybe big projects that come and they give them lots of things. And they are used, you know, to getting large sums of money and stuff like that. But for us, it worked very well because we had freebies, few things to give them, and the training, capacity building would give them certificates. And I think those are some of the motivators. And you can see some of these there's that intrinsic motivation in them. But I know these challenges come one way or the other. But maybe it depends now with where you are and you try to strategize how to go about it. But of course, our ministry gives them some allowance, which is not much, but to them, it's something else. And then whatever comes from the project partners is an add-on. And it has worked very well with us. I hope I've answered you.
Yeah,
But I know there is no one-size-fits-all answer. It has to be your situational analysis. And you see what works. And if you have to scrounge for resources from other programs, you can do so, or you can ask other partners who are also working within your certain given area. That's why I said we always do mapping exercise to see who is doing what, and we pull our resources together, and together we can make a difference. It will go a long way. Thank you.
Thank you. Can I move on to the next question? Okay, I think I've learned something from you there is to keep those community workers and use them for every program that comes up so that they could keep them constantly going. I will try that in Cameroon. We will try that. To the next question is on the local manufacturing in the East African community, and I'm glad they are trying to revise the law in those countries around. I just want to ask our presenter, is it not possible to get these manufacturers from India, China, abroad, who are actually selling products in this community, in the East African countries, put it as a law that once you come and resell a product to market in those regions, you are given a time span, let me say 5 years to market, after which you must build a manufacturing plant within those regions. Instead of us cracking our heads left and right to promote local production, let the manufacturers come and manufacture in that region. So in that case, the local production is done there, done by the manufacturers themselves. Thank you.
Can you hear the question, Daniel? I hope you're still online. If not, the audience has answers too. There's more question?
Yes.
Okay, go ahead.
Thank you, sir. Thank you, Dr. Schneider, for the insights you gave us. Really, they give a clear understanding of your knowledge of how our health sectors work in Africa. great reflections on community involvement. I think the philosophy of working on communities versus working with the communities has eaten up our projects and programs that are meant to improve health delivery of services. I think quickly for me, one is sharing, the other will be a question. The sharing, you did mention, my name is David Chimba. I work with Uganda Protestant Medical Bureau. From Uganda, we coordinate over 330 Protestant faith-based institutions in Uganda. And so when you mentioned the Chisizi story, by the way, my director is here, Dr. Tony. I think he can put up his hand from where he is. Why? Because he was one of the initiators of that program at Chisizi Hospital. He's somewhere there. So exactly. So for us who want to share lessons about that, you can reach out to him. But what we are doing at UPMB is really encouraging community kind of funding mechanisms for health programs, because we are learning slowly but surely that governments are not going to do all what we can. I think the issues of financing are cross-board on a wide spectrum of countries. So what we are doing basically is to engage different groups, community groups, in a kind of community health financing mechanism or insurance for their kind of a pro-payment for your services if you wanted to access them. As you mentioned, reduce the outright out-of-pocket expenditures when need comes around. So we are working with different communities, health facilities being one of those. I think actively we have now about 45 of them. But also other communities like the clergy. We have what we call Kingdom Development Organization. We have many clergy subscribing. So in total, we have about 517 community groups working with that program. And with almost an annual premium of 2 billion Uganda shillings in that kind of program. So they are just part of the efforts we are trying to engage in schools, like I mentioned, among the clergy, but health facilities also, but also going in other organized stakeholders to try and sell the idea. We are not yet there, but I think we are taking baby steps to make sure we co-finance those programs as needed. But also we are doing something more, engaging the local congregations, which has been also a challenge, trying to sell the idea that they can to make a contribution. And what we have successfully done, I think in the previous year or so, is to try and support the Anglican Church to develop a health policy. And part of the financing mechanism to support health services in that policy is that congregations are required to make a contribution of 0.5% from their Sunday collections, wherever they are, to make a contribution to the health programs in that particular diocese, for example. We hope when it takes off, of course, it comes with a lot of encouragement, but we are saying perhaps it will also go a long way to make that kind of contribution. So lastly, my question is, those I mentioned and more, will call for increased demand from the community itself. I think from the supply side, partners and all, we are doing what we can, but what can we do to better the demand of services, but also quality services, but also quality engagement of the communities that we work with? Thank you.
Thank you very much for that example from Uganda. I think it's great, and it's great that you involve the congregations and the diocese to start, complementing what we have. And I think if it's like a puzzle, we have to use these different building stones for the health financing system. And if we put them all together, I think we will strengthen the entire system. So I think that's a very, very important part. I think what we haven't really materialized and used well enough is the reduction of costs that you create when you digitalize your entire system. We all know what happens when we start collecting $2, $3 and $5 and $10 cash from a local rural community, and we carry it to some place and we register it and we put it into a bank account. The administration will swallow it all up, the cost. Even if there's no corruption, the administration will be prohibitively expensive. So now we have the digital means, and digital money is, is everywhere now in the African region, and it's growing. And you have a means of using this pathway to actually create funds, to save funds. And we have our colleagues sitting here from DRC, where we are just working with a saving system where every family can save on their mobile phone their little money they have and use it just for health. And it's reserved for health. You can't get to that money to do anything else with it but pay your health expenditure. So you encourage people to start thinking preventively and start saving. And it's not that one intervention will solve all your problems, but you need to use the mobilization of your churches and digital saving and a mobile health wallet and your mutuelle, and you put them all together and you get each one of those building blocks strengthening your financial structure in order to support the work that you are doing. And I think this is where we need to work together, and we also need to do studies. That's what I meant with implementation research. We need to look at what happens when we do this. How acceptable is it in the local community? What can we learn? And maybe it's different in one country to another, and then get this discussed in our fora that we are entertaining and that we're having like we have today. So I think it's learning together, and health financing is going to be very, very crucial, because the access to drugs, the access to quality of care brings that challenge. And I would like to highlight something else. Sister Gertrud was just mentioning it. We are suffering from brain drain. And I think every one of you can tell a story to that extent. I think we should start looking at a global health worker market, and the church is a global institution. So why are we not using people who have gone? I mean, there have been years, there's Doctors of Malawi in the UK, trying to use, is there not a point when those people would want to come back? How can you use that also the brain drain gets again to become a brain gain, when people who are well trained are motivated to come back to their home countries and start again contributing to their own services. So I think let's think of creative ways of not just letting people go, but say, okay, if you go now, you learn something, you bring it back to us. And maybe get more of that exchange going, because you can't stop people from going, and there's a freedom of choice. And then also to build your local system, discuss, how can the church facility pay in a way that is finally sustainable, that they can live on that salary and they don't have to earn with other thousand other jobs money, and then eventually you lose your quality in your own health service because the quality people. So these are things that I think we should discuss, and we should look at what happens when we do that and how can we learn from that.
Thank you so much. If there is the only thing standing between us is lunch, but I know there is one burning question. Please go ahead. And after that, we'll break for lunch. Please go ahead. Yeah. Question.
The gentleman in the back who was raising their hand.
Merci de la parole accordée. Et j'en profite aussi pour saluer votre brillante présentation, surtout celle de Madame Gisèle et celle qui est à côté d'elle. C'est vraiment aussi smart que ça. Néanmoins, j'avais 3 préoccupations. Premièrement, il faut dire que je suis le professeur Dr Chancelier Chirimwami. Je suis spécialiste en psychopharmacologie sociale et j'interviens plus dans le contexte sanitaire pour les cas de crise. Alors, ma préoccupation va tout droit auprès du docteur Gisèle. Elle nous a longuement parlé par rapport à toutes les stratégies idoines, n'est-ce pas, mises en place par rapport à la prévention et ce qui a été fait lors des différentes épidémies. Mais néanmoins, je voudrais savoir ce qui a été fait à ce niveau en termes d'implication et participation inclusive de la communauté, en dehors, bien évidemment, des communautés et des relais communautaires, je vais dire par là, et des associations des églises. Supportez-moi, je viens du Congo et voilà, donc je parle en français en tant que, bien évidemment, inspecteur provincial de la santé au site Kivu de la République démocratique du Congo. Il y a un autre aspect, là où elle a fait allusion, c'est par rapport aux stratégies. Il y a des stratégies de proximité qui ont été mises en place, mais il y a quelque chose auquel elle n'a pas bossé, c'est la communication. Eh bien, qu'est-ce qu'elle a fait ou qu'est-ce qu'ils ont fait à leur niveau pour que la communication atteigne des personnes vulnérables, ça veut dire au-delà de la couche des populations qui sont suffisamment instruites pour atteindre la dernière couche des communautés, n'est-ce pas, qui ne sont pas instruites. Et comme troisième préoccupation, avant de libérer la parole, je ne sais pas si je vais qualifier cela comme une question ou alors une recommandation ou alors une doléance particulière. C'est en fait généralement sur le plan méthodologique par rapport à l'approche pédagogique. Lorsqu'il y a une conférence ou un colloque pédagogique, qui peut être bien entendu andragogique, lorsque ça va au-delà des 48 heures, c'est qu'il y a toujours des documents qui les sanctionnent. Ça veut dire que les colloques en soi doivent être accompagnés, si pas par un brevet, soit un certificat pour la visibilité. Je me souviens, l'année antérieure, nous avons été par exemple au niveau de Nairobi, si j'ai bonne mémoire, à Kisibi, voilà. Et donc, à son temps, j'avais encore soulevé cette préoccupation-là dans les couloirs, comme quoi il serait aussi mieux, toujours, n'est-ce pas, d'accompagner les participants par un document, soit un brevet, soit, c'est pas, ça dépend des qualificatifs de tout un chacun de nous. Voilà un peu ce que j'avais comme, n'est-ce pas, préoccupation. Merci.
Merci pour les questions. Je pense nous continuons la discussion après notre plénum ici parce que c'est beaucoup de questions. I think we have a lot of questions that our colleague raised, and I'm offering to also discuss them afterwards in more detail, and maybe we can get to some of those questions because I think it will be beyond the panel here. If I look at MPOX and all, what can we do with the community health workers and how to use the community health workers on the risk communication and other issues, I would like to discuss that with you afterwards when we have a chance, maybe in the lunchtime.
Thank you. Mwai, do you want to go ahead?
Thank you. Mine may be a question, if it cannot be answered, maybe a food for thought, but pertaining to promotion of local manufacturing in the region, including the aspects of regulation, legislation, standardization, and all that. Would this be an opportunity to promote traditional or herbal medicines that we have been losing in the region? And we know that they actually have value. Would this be an opportunity to revive that and reclaim some of those assets that have been lost?
You want to answer? Anybody wants to answer? Yeah. Dr. Gisela?
Well, I think you have a point there. There is a lot of value, and it is again a whole subject of how to do the studies to underpin, effectiveness, etc. Some studies have been done, others would need to be done, but I think it's an important subject when it comes to access to medicine, also to look at herbal remedies and local medication that has been there for hundreds of years and been used in different ways, and I think there's value to it, and I think they should be given that value, but I think we should also evaluate and do the necessary researches that need to be done to really, then make this into a policy and strategy.
Richard, you want to answer also?
Yes, I would like to answer to the first question and also come to what Mwai has requested. So for the certificate, the participant requests if we can provide an attendance certificate. I think we can discuss about it and see how this can be done. But for the traditional medicines, I think we are overlooking it while it's really another type of pandemic, because we have good ones, but we have also many who are misusing the information related to those traditional medicines. So I feel we need to start thinking about it and together see what can be done. And as Gisela says, maybe we need to start by looking on what are the practices, what are the outcomes. We could also ask those who are still doing their studies, young pharmacists, maybe to start looking on those products and how these traditional healers are working. I have an experience in DRC. My grandfather, he was very close to me, and he got the prostate problems, and he was very old, 80 years, but he was still very active. And with all the issue of sexual limitations, he want to get good product for that. And all over the city, he's very keen in following news. And actually, those traditional healers, they have also power to use media to attract people to their clinics. And I took the time to follow him because it was difficult for him to understand that I don't want to move with him in this direction. So I decided, let us go. And I was keen to see the number of people who were there. I was really shocked. Many people who are, because they are not able to go to the hospital, the clinics, the cheapest way to get the medicine is to go to the healers, those traditional healers. And I decided to enter with him in the clinic. The doctor, healer did not want to let me enter because he knew that I'm instructed. And if I enter there, I will find all what he's doing. So I decided to get in with him, to push to be there, and I was really shocked. The diagnostic, the way he's doing it, he's talking about technology which you look at it, it's not a technology. You just put your hand there and it will detect all the disease you have. and from there he will decide what you are suffering from and so on. But it was not true. So I would really recommend maybe we start thinking about this and see where is the value and how we can also include education in our work as community healthcare workers. You know, they can also play a key role in providing the right message, but on the other hand, look on what are the key outcomes which can push for more studies and engage. Thank you.
Very good conversation, excellent. I do have 2 more hands up, but 3 probably. But thanks, Mai, for provocating our conversation and question with that particular question, and thanks, Richard, as well. I can tell you, as someone who has extensive experience using alternative complementary medicine, I practiced, I've treated, I have proof, I've made people to stand up and walk, so I know it definitely works, but it is something that has to be rigorously studied, and different systems of medicine need to work together. The mindset has to change. What one cannot do, the other can do for sure. But that says deep research to be done. But I'm a testament here, directly practiced for many years. But I'll ask you for your question, please.
Okay, thank you so much. I'm Mario. I work for a West African organization called Museum. For the Francophone, it means Mouvement Universel pour la Survie de l'Humanité. And yeah, I will just address your last intervention before going for what I was about to say. It's good to depart, I would call them magicians, from traditional or alternative medicine, because definitely we have a good asset to leverage on from that kind of medicine. And in our context, in low-income countries, people, for some reason, believe in them. So I'm part of those who believe that we can work together and make it happen. Okay, my intervention is not a question. I wanted to thank Dr. Gisela for her compelling and inspiring presentation. She mentioned some values that really resonate with me and my organization. I'm talking about solidarity, caring about each other. And in addition to that, I want us as people of faith, Christians, and also health workers, to advocate for a world where nobody dies because of the agenda of others. You know, I'm talking about peace in the world, because as long as we won't be in a peaceful world, there's no equity and access to healthcare for all. So I would like us to be courageous voices in this direction, to speak out and fight against injustice in the world. And I'm happy that the topic, the theme of this conference is access to healthcare for all. And that, especially in the African continent, there's so many conflict zones, and we need to talk about it. We need to be vocal about it as Christians, as healthcare workers, because we experience it on a daily. We know what our community are experiencing, and at times, the health system is not really the problem. The facilities are there, the structures are there, but due to security problem, they can't access the system. So that was my intervention. We can be a good advocate for a world where our health systems are based on compassion and solidarity. Thank you.
Thank you. Thank you so much. Please, you are good. I know that this is exciting, lots of conversations. I'm not going to stand in the way of lunch, but you can ask the question. Please go ahead.
Yeah, thank you. My name is Julia. I'm responsible for international health policy at Bread for the World. And I have two questions for Daniel. I hope that he's still in the digital room. You were talking about enablers, but also about challenges and obstacles in manufacturing pharmaceutical products in the East African country. And from my perspective, I'm sure that there are also obstacles regarding the global drug system. So I'm speaking about the protection of intellectual property rights and patents. So will you include also an international perspective in your work? And you were also talking about the development of a policy brief. And I think there the international perspective would be so important that the governments of the East African countries can advocate for their interests and do lobby work at the international level, that this unfair system of drug manufacturing will hopefully sometime be changed. Thank you.
Thank you for the question. I'm not sure Daniel is online, but your question is obviously important, and I hope if anybody else wants to answer, please go ahead.
No, I think it's an important part. I mean, this whole question we have not discussed this morning, but I think in local manufacturing, it's always part of a global market, and you have to look at how the effects are and the roles patent play. Would be a whole ball game to discuss that. I think we should maybe convey that to Daniel, and that he can mention something, maybe in writing.
Yeah, will do. Any other questions? If I ask, I know there will be more hands, but in the interest of time, maybe we can call it, right? We can conclude our sessions. Please, let's give a hand of applause to our speakers and all who asked questions. Thank you so much for your time. Enjoy your lunch, don't sleep, come back for the next session.
Okay. Thank you very much, Dr. Dennis and the team. Thank you very much. As we break for lunch, okay, thank you very much. As we break for lunch, before we do so, can I kindly request that the moderators for the breakout sessions, for the afternoon sessions, they come up here so that we see them. We have Dr. Lillian Ngaruya from EPN. Please come up. She will be moderating the first session, breakaway room, which will be in the main conference, which is this one. Lillian, are you here? She is not here, but for those who would be joining the first breakout session, where we will be discussing empowering healthcare professionals with the church health system through innovative capacity building approaches. It will be happening in this room. It will be moderated by Dr. Lillian. She is here. The second breakout session will be in breakout room number 2. The venue will be Zebra.